Hey, good morning, everybody. Welcome to Bible class. Today we have Victoria Fox, whom I know you all oftentimes see here, sitting over there in that area. You know, that's how we take attendance in church. You know, while we're up there in the pulpit, you know, we're up there counting noses. You know, so most of you sit in the same spot like we do every week, so it's easy for us to count. Anyway, Victoria is a licensed nurse practitioner, and so she went back to school after being, because when I first met you, you were a nurse, right? And then you went back to school and became a nurse practitioner. So lucky you, I'll tell you, she's a glutton for punishment. So today, there's a lot in the church right now where we're talking about not only spiritual health, but our emotional and mental health. And there's always a concern. Right now, the Lutheran Foundation here at Fort Wayne is running a really big program on helping people to deal with emotional issues. And we know that even in the church, we certainly aren't free from those cares and concerns. And that from time to time, the challenges of life are overwhelming. And so, you know, it's not a bad thing. I mean, if you fall and break your arm, you're not embarrassed to go to, you know, the hospital to get it repaired. Well, what happens if your heart's broken? You know, well, for some reason, we've got all kinds of stigmas on that, and that's really sad. So we're trying to get away from that. And so Victoria, who works in this area, is going to have a presentation for us today. So we're going to turn it over to her. Also, I have a little sheet here about helping us out with coffee and cookies. And some of you saw it over there and signed up already. We're just going to pass it up and down. And if you want to volunteer, great. If you don't, sweat us down not. Just pass it on. So I'll start here. We'll pass it. We'll zigzag it through the group. All right. Thank you. Victoria, the floor is yours.
Okay. I apologize. I've had this upper respiratory junk for like a month, so I'll probably cough off and on. But I'm not sick. I'm just allergic to everything in life. So I am a family nurse practitioner. I do work full-time at Parkview Physicians Group. I also, on top of that, do have a bachelor's degree in psychology, and I work at a counseling center one day a week. And I also am adjunct faculty at St. Francis. So I do a little bit of everything. So, like Pastor Shoemaker was just saying, I'm just going to give a presentation. There'll be time for questions. Open it up to anybody that has anything. Basically, just giving a little bit of a back history of mental health, what it is, how it's been perceived in the past in the church, some definitions of some of the big things that we see, and how to move forward. So, what is mental health and mental illness? The Lutheran Center for Spiritual Care and Counsel defined mental illness as a serious disturbance in thinking, mood, or behavior that usually involves distress and impairment in the ability to cope with everyday life. Symptoms can include excessive fatigue, anxiety, depression, feeling of hopelessness or worthlessness, thoughts of suicide, extreme swings in mood and personality, and that's just to name the big ones. The Mental Health of America, a long-time community-based nonprofit organization, has completed one of the largest screenings ever. They screened over 1 million people, and about 1,400 people screened for depression daily. 66% are under 25, and in total 59% are found to have serious depression. So it is something that we are seeing more and more with today's youth. There are a lot of changes that are very different from when we were growing up. The culture is a lot different. The pressures that they have are different. The environment that they're living in is different. So it is going to be something that we're seeing more and more of, and we definitely need to start addressing it. Some history of mental health in the church. It is just now kind of being widely discussed. Depression in the congregation is being widely recognized, and there is a lot of research going into how religion can play a role in breaking down the stigmas that surround mental health. It's also becoming a place to find comfort for those who do have different mental health conditions. Our own Martin Luther is thought to have suffered from depression or at least severe anxiety and melancholy. It's clear in some of his writings in older age, but there is also some discussion that even in his youth he may have suffered as well. Author David Armstrong talks about that some of these may have had a physical basis because he did have a lot of physical conditions as well. Luther describes his own suffering, talks about persistent maladies, and one of the things that he said was, "I fear more of what is within me than what comes from without." And he also did say, though, even if I knew that tomorrow the world would go to pieces, I would still plant my apple tree today. So that he was able to acknowledge that he did have his own personal struggles. Among people who are worshiping in any American church, up to 25% are likely touched by mental illness. So that means that it is somebody sitting next to you in a pew, a family member, a friend, or perhaps yourself. At the core of the church's misunderstanding is the belief that a great sin must have occurred to create this psychological problem, or that it's a demonic infestation. Historically, there's been a lot of stigma surrounding mental health. 92% of pastors talk about mental health once a year, rarely or never. So that means it's really not commonly addressed, especially in the daily sermons. Fear about speaking on this subject in the church sends the message that the church's, it's the opposite of the church's objective of being a safe, welcoming place for peace seekers and those in need of care. So not that the church is outright saying anything bad about it, it's just not addressed. And so when it's not addressed, people feel like they're not welcome and they're misunderstood. An article published by the Journal of American Medicine found that women who attended religious services had a lower risk of suicide compared with women who never attended services. Women who attended once a week had 5 times lower risk of a subsequent suicide attempt. So it is acknowledged that, you know, church can be a place of healing. We just need to do better and reach out more and help people. A lot of you are probably familiar with Rick Warren. His son committed suicide a few years back, and so he did start to speak out about this after his son's suicide. He once said to his congregation, "There's no shame in diabetes, there's no shame in high blood pressure, but why is it that if our brains stop working, there's supposed to be shame in that?" And so what we've done is create a divide between the body and the soul. So we focus on caring for our soul in the churches, and we don't really talk about the health of mind, body, and soul and how they're integrated, and how when you have physical illnesses, when there are physical problems going on, that may affect your mind. And mental health is often thought to be a weakness or a lack of willpower. And many Christians are not encouraged to seek counseling. Many are encouraged to pray harder and have more faith. And that really does a disservice because there is a physical component to it. So we'll talk a little bit about that here in a minute. Some more stigmas. 26.2% of adults, or 1 in 4, suffer from mental illness within a 12-month period. The same study also estimated that 5.8% of adults suffer from a serious mental illness. And a 2013 study from Lifeway Research found that 48% of evangelical Christians think that mental illness can be overcome by prayer and Bible study alone. So although 1/4 of us suffer from some sort of mental illness, half of us feel that it can be solved by prayer alone. And so when it's not solved by prayer alone, you start to feel that there's something wrong with you or your connection, your spirituality, something is wrong with you because you just can't pray it away. Some of the other stigmas, the myths include reading the Bible is sufficient for your healing. You shouldn't take medications because mental illness is rooted in spiritual issues. You'll be healed of mental illness when your pastor forgives your sins. And it is really talked about that mental illness is part of the result of the fall. So it is like all other disordered creation. We have cancer, we have diabetes, we have heart attacks. All these things because of the fall, and your brain is an organ, and your brain does start to deteriorate like the rest of your body. So it is caused by a biological, social, and psychological factors that require a combination of treatment, including counseling, medication, and spiritual care and life changes. So it is really caring for your entire body, your body, your brain, your soul, your mental state. They're all intertwined, and we have a real disconnect, especially in our society. We just think that body is separate from spirit, is separate from mind, and we need to start looking at all of those as intertwined. There's a quote in different things talking about mental illness. I remember that I could hear all the right words, read all the right Bible passages, hear the absolution, receive our Lord's body and blood, and at the end of the day, think to myself, that's all fine and good, but they don't apply to me, I'm too far gone. That's not true. It's what Satan wanted me to believe. Satan can use disease, disaster, really anything to draw you away from Christ, and he loves to use them all. The help I needed was spiritual and medical and psychological, because I'm one person, body, soul, and spirit. God can work through all different kinds of people to effect healing. The comfort of his word, the balm of medicine, the insight of a counselor can all be at work. And then there is this study over here was something that, when I talked about this last time, Pastor Stecker really had wanted to hit home with. There was a study done by Lifeway Research, and they found that 55% who never attended a worship service felt like if they had a mental health issue, churches would welcome them, but only 21% who attend services once a week or more felt welcome. So that's really sending a message that the people who are not familiar with church feel that church is a place that is welcoming and open, but the people who actually attend church services weekly do not feel like if they came out and said that they had a problem, that they would still be welcome in their church, that they could find shelter and help within their church. So that is something that we really need to talk about and address. Like, how is it that we as a church could be more welcoming and understanding to those around us, because they are in our church, they are our friends, they are our neighbors, they're our parents, our children, and we need to be able to embrace them and lift them up instead of making them feel that they're not welcome, that they shouldn't be talking about their struggles. So some examples of diagnoses include anxiety, mood disorders like depression, schizophrenia, eating disorders, impulse control and addiction, personality disorders, obsessive compulsive disorders, and post-traumatic stress disorder. I am just going to talk briefly today about 3 of the ones that we commonly see in family practice and that we commonly see in counseling centers, and that would be dementia, delirium, and depression, what the differences are, because they appear very similar. Especially because we do have that baby boomer generation that is starting to age. So we've got the largest cohort, the largest group of people are starting to be aging adults. And so we really need to be able to address that, because people are living longer and they're maintaining their health for longer, and sometimes they have more physical decline in the brain than they do on their outward body. So being able to, kind of decode what's going on and seeing how we can help. So, dementia. There are multiple kinds of dementia. The one that we most commonly talk about is Alzheimer's, but there's also Lewy body, Parkinson's comes with a form of dementia. There's a whole group of people that do start to suffer from dementia. The risk of developing dementia rises with age, and approximately 1 in 3 people over the age of 90 will have dementia. Dementia is a term for a group of conditions that cause a decline in brain function and difficulty with memory and attention, orientation to time, place, or person, language, reasoning, and judgment, regulating emotion, processing information. So since many illnesses can affect cognitive function, initial screening tools aim to exclude other causes. So we draw blood, we check thyroid function, we make sure there's enough vitamin B12, folate. So there's physical causes that can make it seem like dementia, but it's actually something else physical going on. So making sure that we check to see that there's no medications that could be causing cognitive decline. We normally refer out to a memory clinic, neurology, psychiatric services. So there's lots of other specialties that can help diagnose and treat. And then there are lots of treatment options. So physical therapy, occupational therapy, vocational rehab, like pet therapy, music therapy. There's all kinds of things to keep the brain engaged. But it does have a physical cause. And so we can see now with being able to scan brains, normal brain function, some mild cognitive impairment, and Alzheimer's disease. So the brain actually starts to deteriorate and not make those neural connections anymore. So we can see that this does have an actual physical cause. There is no current medication that can reverse the dementia process, but we can slow it down with a lot of different medications. So there's treatment options out there to kind of help prevent the progression of Alzheimer's disease and Parkinson's in the body. So like I said, drug treatments. Make sure that we're maintaining independence, letting people do what they can for themselves, encouraging them, even if it takes longer, even if it's frustrating, encouraging them to do what they can for themselves and keep that brain healthy and active as long as possible. So anytime they're using their brain, that if you don't use it, you lose it sort of thing is true with the brain as well. So we need to make sure that they're doing what they can to stay healthy. Another thing that is important with dementia is focusing on the lived experience. So trying to understand why they're experiencing stress in that moment, not always reorienting to reality. So if they're trying to find their spouse and their spouse has already passed, there's no need to tell them again because they're reliving that experience over that their loved one is not here. You know, trying to be with them and live in the moment with them and try to relieve what's going on in that moment instead of reorienting to reality because they're learning all over again that their spouse is dead. Or they may not understand or believe you, and so there's fear and agitation. So just living in that moment with them and trying to help them through and just kind of promoting the peaceful aspects and the calming aspects and reassurance that they are okay and they're safe and that they are loved. So another thing that we see is delirium, and a lot of people mistake delirium for dementia. But delirium is a sudden deterioration in mental functioning. So mom was fine yesterday, she was out getting the mail. Today she doesn't know who you are, she forgot if she's ever eaten breakfast or not, she can't get herself dressed. So it's a sudden onset. And it is usually triggered by an acute illness of the body or brain, acute injury, or drug intoxication. It's common and it's a serious medical emergency. The condition causes significant distress and is associated with poor outcomes, including increased risk of dementia, death, and long-term care admission. So a lot of times this goes unnoticed for a while, especially if the older adult is living on their own. 1 in 8 hospitalized patients and 20 to 30% of those on medical wards have delirium. It's not often detected or diagnosed. A lot of the time it is just thought when they're admitted to the hospital, oh, well, this person is older and they must always be like this. And so the illness is not necessarily treated properly or acknowledged because when they go to the hospitalist doesn't know what their baseline functioning is. So if you wind up going to the hospital with a loved one and their cognitive status has changed, make sure you're telling that physician or nurse practitioner or PA, the nurse in the room, when you're just going to a primary care doctor, like make sure you're saying this is not them, this is not how they normally act, this is sudden, it's a new change. And that can be one way that is investigated further because oftentimes it is unrecognized until it is too late and there's a very serious illness that is occurring. So, number of possible causes. Causes include infection, constipation, dehydration, change of environment, metabolic disturbance, trauma, hypoxia, which is low oxygen, or drug withdrawal. So a lot of what I see in primary care is urinary tract infections. So common. When the body ages, the brain and the organs don't always talk to each other like they do when we're younger. And so people can have urinary tract infections that go untreated, go unnoticed until they become toxic, and it can actually kill them. But a lot of times I see patients in the office that, mom's not acting right, she can't remember if she took her medicine today, she's just not herself, I don't know why, and it's a very serious infection. There's an easy screening tool within the office to check for this, but it goes unnoticed for a while because it's very insidious and it comes on slowly. The actual infection does. Another one that we see is hypoxia, low oxygen. So COPD patients who were smokers, patients with different lung infections over time, they're not getting enough oxygen, and their brain just gets less and less oxygen, they're short of breath, and they start to lose that cognitive ability too. So getting them back on oxygen, all of a sudden mom's back, like she's here. We had a case like that in the office. He had brought his mom to his appointment. It wasn't even her appointment. He's like, there's just something wrong with her, so I brought her with me today because I didn't feel like I could leave her alone. We put a pulse ox on her, oxygen was 72, just sitting in the office. So she was not getting enough oxygen, and then we sent her to the ER and treated her. But so little things like that. She may not be blue, she may not be gray, she's just kind of slowly, over time, losing that ability to breathe. So some prevention for delirium. Making sure that we are checking on the family members, like talking to the family members. You are that advocate, because if that person is having struggles, they may not be able to tell that nurse or that doctor. So involving family members in the care, making sure that we are getting adequate hydration and nutrition, detecting and treating pain. So pain is kind of the fifth vital sign, and a lot of times patients that are in pain become confused, so making sure that pain is adequately treated. Getting rid of infections, trying to avoid catheterization in the hospital because that is a common cause of infection. Reviewing medications, avoiding certain drugs, so there's it's called the Beers list, and there's medications that once you become 65 you should no longer be on because of the risk. A lot of the like Benadryl increases your risk for confusion as you get older. A lot of the anti-anxiety drugs that we used to use, benzodiazepines like Xanax and Ativan, they start to cause a lot more confusion, a lot higher risk for falls, some blood pressure medications that lower your blood pressure too low. So there's a lot of medications that we may have been taking our whole life that become much more risky after the age of 65. And then of course making sure that we're actively using our brain and getting adequate sleep. So once we detect delirium and figure out what is going on, the treatment is usually getting rid of that infection, getting rid of that pain, whatever is causing the problem, it's kind of going back and fixing that. So signs and symptoms of delirium include impaired attention, memory disturbance, disorientation, disorganized thinking, altered perceptions like visual hallucinations, illusions, and emotional disturbance. So a lot of those things are very similar to what we just talked about in dementia, but it's that sudden onset where the loved one was fine 2 days ago and now there's something going on. Making sure that we're doing person-centered approach, so prevention and treatment may overlap. Needs such as pain, hunger, thirst, sensory age should be identified and addressed, and staff should adopt a reassuring approach. So again, that being in the moment, that you're safe and that everything's okay and that we're taking care of you, and that definitely can come from family and friends as well. And then lastly, depression. And depression, of course, affects people of all ages. This was kind of a screener or like discussion geared more towards older adults. But it's common, underdetected, and underdiagnosed. In older adults, symptoms can be slightly different than those for younger adults. And one example is older people may experience more physical symptoms and increased anxiety or agitation. Sleep disturbance is also common and risk factors for depression. Higher risk of suicide among older people with depression. So it is low mood, loss of interest or pleasure in activities. Other symptoms include irritability and anxiety, social withdrawal, pain, fatigue, reduced or altered sleep and appetite, feelings of guilt and worthlessness, and reduced self-esteem. So there's all kinds of assessment tools that we use for this. Going in and speaking to your primary care provider, saying, I'm feeling this way, or I've noticed these things. There's lots of different tools that we use, different questionnaires, different guidelines, and treatment can really vary based on the needs of the adult. So, but the big thing is that depression does have physical causes, and we can see this. So, again, now that we're able to look at brains and look at scans, the not depressed brain versus the depressed brain lights up very differently. There's lots of activity going on in this brain of a healthy individual. With someone with depression, there's less stimulation going on. There's less neuroreceptors that are being lit up. So there are different chemicals that play a role in this. Serotonin, norepinephrine, dopamine, different catecholamines. So there's all these chemicals that we're supposed to be producing that float around in the brain and stay in the brain and help the brain function, just like the rest of our body. And when those chemicals are not being created, or they're not being created properly, or they're being broken down too quickly, we get these physical things going on. And so that's one of the things that medication really does, is help those chemicals come out appropriately, help them stay in the brain as long as they're supposed to, help the body not break them down as quickly. And so when we use medication as a tool, it is to help with those chemicals that are supposed to be there to help our brains do what they're supposed to do. And those chemicals do actually exist in the rest of the body, and there's receptors in the rest of the body. So a lot of times in children, what I see is upset stomachs, diarrhea, vomiting, because there are receptors everywhere in the body. And so especially with something like anxiety or depression, your brain is telling your body that there's a fight. You have this fight or flight, and your brain is saying, like, we have to panic, we have to get out of here, there's something wrong. Even if you can look around and say, like, I'm in a safe place, your brain has already flooded your body with all these chemicals. So you get increased heart rate, you get increased blood pressure, you get sweaty, you get hot, you get sick to your stomach. And all of that is a physical manifestation of something that's going on in the brain. And so there is this like mind-body connection with depression that we're just now starting to learn more about due to advances in imaging, advances in science and studying the brain. So there's lots and lots and lots of treatment options, and sometimes it can be frustrating because you have to figure out what's right for you, what's right for your loved one, and it's not just a one-size-fits-all sort of thing. So if we think about when we go to the doctor, there's like 30 different blood pressure medications out there, and sometimes they're like, we'll try this one, and well, your blood pressure didn't come down, we've got to try this one. So even when, it's a well-studied thing like the heart, we still don't know what's going to work for you. And so that's the same with treatments for mental illness. There's lots of medications, and there's lots and lots of non-pharmacological interventions. So a lot of times it's figuring out what pieces you need to make you feel better. So non-pharmacological treatments include cognitive behavioral therapy. There's a lot of science behind that form of treatment for depression, anxiety, other mental illness, but it's not just that therapy that you think of where you sit on the couch and talk and somebody listens to you. It is a therapy where there are workbooks, there are guidelines, you work through things, and you get tools to cope and interrupt that thinking, because a lot of times it's disordered thinking, and you have this thing that's playing in the back of your head all the time, no matter what. You're not good enough, or that people don't like you, or that something's wrong, and it's recognizing that and finding ways to stop that. So cognitive behavioral therapy helps with that. Interpersonal therapy, behavioral activation, counseling. So there are lots of different treatments. Mindfulness, sleep hygiene, getting out and getting physical activity. So exercise is something that we all underutilize. 30 minutes of physical activity every day releases chemicals in the brain, and those same chemicals that make us feel good, and a lot of us underutilize exercise, getting the proper nutrition. So a lot of times what I see with patients who come in with depression and fatigue, we all live in Indiana and none of us get enough sunlight. And vitamin D is actually a building block for serotonin. So you don't have enough of this vitamin to create the chemical that your brain needs. And so I test for vitamin D on like all my patients that have this, and most of them have low vitamin D, and they need this supplementation. Folic acid is another one. About anywhere between 25% and 50% of us have a gene that we have found that even if we're taking in folic acid, women take it in when they're pregnant to help with neural development of the baby, but even when we're taking in this folic acid, it may not be converted properly, and we may need a different form of folic acid, and that does play a role in depression and anxiety and different mental health things, as well as development of the baby. So now we're also seeing women who are having multiple miscarriages. We test for this genetic marker, we stick them on a supplement that's over the counter that's a different form of folic acid, and they're able to have babies, their depression improves, their anxiety improves. So there are physical reasons why these things occur, and we're just kind of starting to be able to learn some of those treatments. So it's really cool to kind of be in on that and the genetic testing component. So what can we do to help? It starts with acknowledgement that depression, suicide, addiction are common realities. They're, ailments that we all know somebody who has suffered with this. So, we see people that have strokes, we see people that have heart attacks, we see people who are injured, and we go to the hospital and we say like, hey, I'm sorry that you are struggling, what is it that I can do? Let me be there with you, let me make a meal, let me make dinner. Oftentimes when somebody is suffering from depression, we don't reach out. It's a lot harder to know what to say or do, so we just do nothing. Instead of still saying, I'm here for you, I'm sorry you are going through this, what can we do together? Let me make a meal, let me check in on you once a week. I'll have a phone call, what actual thing can I do? What is so overwhelming to you? Can you not vacuum because it's just too much to clean up your house? Let me help. So there's all kinds of things that we can do to be there with that person just like we would if they fell and broke their leg. It's also big and scary because when somebody has a heart attack or somebody breaks their leg, we know that that is going to resolve. Like broken leg, 6 weeks, you're back up. Something like anxiety and depression, it's kind of nebulous, and I don't know how long I'm going to have to offer to help, and maybe this person's going to need more than I can do, and I just don't know. But still just reaching out and being there for that person. We need to start doing things like that. So the National Alliance on Mental Illness has family meetings, so you can go and learn more about just how to be there for that person. Not all of us have